Welcome to Vitals and Veins, where we break down the real work behind patient care, built for medical assistants, phlebotomists, and EKG technicians, from students working toward certification to seasoned pros keeping their credentials current. This podcast is for those committed to doing the job well at every stage of their career. Let's get into it. I'm your host, Nichelle, and joining me today is my friend, fellow medical assistant, and co-host, Kirsten.
Hi everyone, I'm really glad to be here. I'm Kirsten, and like Nichelle said earlier, I'm a medical assistant, and I'm excited to talk about this topic because sharp safety and exposure response is something that affects almost everyone working in clinical care at some point.
Awesome. So, in our last episode, I shared a personal sharps exposure experience and we analyzed where the system broke down. Today, we're shifting the conversation to something constructive, what a gold standard exposure response system should actually look like in clinics. So, Kirsten, before we get into the workflow itself, when you think about sharps injuries in healthcare, what do you think people misunderstand the most?
Hmm, that's a good one. I think one of the biggest misconceptions is that Sharps injuries are rare or they only happen to people who are inexperienced. In reality, they happen in every type of clinical environment: outpatient, clinical, hospital, labs, and often to people who have been doing it for a long time. Another thing people underestimate is the number of exposures that happen during specimen handling, not just collection. People often think about injections or IV placement, but things like transferring blood, disposing of sharps, or handling collection devices can also create risk. And over time, experienced staff sometimes normalize that risk. We get a little used to things.
Mhm.
When you're doing these tasks all day, every day, it can start to feel routine. But that familiarity can sometimes make people a little less cautious than they would be in a high alert situation.
Yeah, for sure. I mean, do you think that people are sometimes reluctant to report exposures because they think they're being blamed?
I think that absolutely happens. Even if the organization doesn't intend to create that environment, people can still feel like reporting an exposure means that they're admitting that they made a mistake. There can also be the internal pressure where someone thinks I should have known better, I should have done better, especially if they've been doing the job for a long time. So instead of reporting it immediately, they might try to downplay it or convince themselves it's not that big of a deal. And in busy clinics, there's also the worry about slowing things down. People know reporting an exposure can trigger paperwork, evaluations, and schedule changes. So they may hesitate because they don't want to disrupt the workflow.
I couldn't agree more. So, next, before we dive into the step by step workflow, I think it's important to step back for a moment and talk about why exposure response systems exist in the first place. So, sharps injuries and other occupational exposures are recognized risks in healthcare. They're not rare events and they're not always preventable in the moment. What matters most is how the system responds when they do happen. In the United States, workplace protections for bloodborne pathogen exposures are governed by standards from OSHA. These standards require employers to have clear procedures in place for managing occupational exposures, including medical evaluation, documentation, and follow up. And an important piece of legislation related specifically to sharps injuries is the Needle Stick Safety and Prevention Act, which strengthened requirements around safer devices and tracking sharps injuries in healthcare settings. So, the regulations exist, and most healthcare organizations technically have policies in place. But the real question is, how well do staff actually know these policies? Kirsten, do you think most clinicians, whether they're phlebotomists, medical assistants, nurses, what have you, actually know what their clinic's exposure protocol is?
Hmm. In my experience, most people know pieces of it, but not necessarily the full process from start to finish. For example, staff usually know basic safety things like where the sharps containers are or that they should wash the area if exposure happens. But when it comes to the full protocol, who to notify, what forms need to be filled out, where to go for evaluation, that's where the knowledge can start to get a little fuzzy. A lot of those details are covered during orientation, but if the topic isn't revisited regularly, it's easy for people to forget that exact.
That's something I've seen too. A lot of organizations have the policy written somewhere, usually in an employee handbook or a safety manual, but in a stressful moment, people aren't pulling out a manual to figure out what to do next. Do you think that people tend to rely more on coworkers than on formal protocols when something like this happens?
Oh, for sure, yes. I think that's really, really common. When something unexpected happens in a clinic, the first instinct is often to ask the person closest to you what to do. So, someone might ask a senior MA, a charge nurse, or a supervisor instead of looking up the official policy. And sometimes that works fine if the person you ask knows the process. But if everyone is relying on memory or informal guidance, the response can end up being inconsistent depending on who happens to be working that day.
Ooh, and that's where systems can start to break down. If staff are relying on memory or word of mouth instructions instead of a clear protocol, the response can become inconsistent from one situation to the
Oh,
next.
for sure.
Yeah. So, what do you think happens in clinics where exposure response isn't discussed very often? Maybe the last safety training was a year ago and the topic hasn't really come up since.
When safety topics like exposure response aren't talked about regularly, people can feel uncertain when something actually happens.
Oh, yeah.
In that moment, staff may not be completely sure what the next step is, and that hesitation can delay reporting or evaluation. It can also lead to inconsistent instructions if different supervisors give different guidance. Um, I think regular reminders or training can really help keep the process fresh in people's minds so that when an exposure happens, it feels more automatic.
Right. And that hesitation can actually increase risk. The longer an exposure goes unreported, the harder it can be evaluated properly. Before we continue, let's take a moment to hear from the educational platforms that support vitals and veins. Studying for your medical assisting exam? CMA Review gives you focused practice questions, clear explanations, and prep that mirrors what you'll actually see on test day. Stop second guessing your readiness. Head to CMA Review and walk in confident. Welcome back to our conversation on the gold standard of sharps exposure safety. So, another thing I've noticed is that some staff assume exposures are extremely rare, when in reality, they happen more often than people realize. Have you ever heard someone say something like, it was just a tiny poke, it was probably nothing?
Yes, definitely. It's actually pretty common to hear someone say something like, it was just a tiny poke or it barely broke the skin. Sometimes people minimize it because they don't want to deal with the paperwork or interrupt the clinic schedule. Other times, it's more of an emotional reaction. People might feel embarrassed or frustrated that the injury even happened in the first place.
Oh, don't I know it?
But even small exposures should be reported and evaluated because it's not always possible to judge the risk just by how the injury looks.
Yeah. And that's exactly why structured systems matter. Exposure management shouldn't depend on whether someone feels comfortable reporting the injury in that moment. It should be a standard, automatic process that everyone understands. So, with that context in mind, why these systems exist and why they're so important, let's start walking through what the first step in a gold standard exposure response actually looks like. All right, so now that we've talked about why exposure response systems are important, let's walk through what the first step actually looks like when an exposure happens. The immediate response after a sharps injury is actually pretty straightforward medically, but in the real world, it doesn't always happen the way it should. In most healthcare settings, the immediate response includes a few basic steps: removing your gloves, washing the site with soap and water, avoiding aggressive squeezing of the wound, and reporting the exposure right away. These steps sound so simple, but in practice, there are a lot of factors that can delay reporting. Kirsten, have you ever seen someone hesitate to report an exposure because they thought it was minor?
Yes, especially in busy outpatient settings. Someone might wash the area quickly and then think about finishing the procedure before saying anything.
Hmm.
Sometimes the thought process is, I'll just deal with it later after this patient. But that delay can stretch longer than intended if the clinic schedule is packed, or you get sidetracked doing something else, or aftercare, all that kind of stuff. It's not necessarily because people don't care about safety, it's usually because they're trying to balance patient care with their own situation in that moment.
Absolutely. And if you were listening to the previous episode where I shared my own sharps injury incident, I did exactly that. I continued on with the procedure and I didn't address it until everything was done because, we had a patient in the middle of a procedure with tissue samples being collected. It didn't feel fair to the provider that was performing the procedure or to the patient to stop everything to
Oh,
deal
for
with
sure.
me. That's
Yeah.
what I thought. So that's something I've seen. In busy clinics, people sometimes try to push through in the moment instead of stopping to report their injury. So, why do you think clinicians sometimes minimize these types of exposures?
I feel like there are a few reasons. Workload pressure is a big one. When the clinic is busy and patients are waiting, people don't always feel like they have time to stop everything. There's also the administrative side. Staff know reporting an exposure can involve documentation, evaluation, and follow up appointments. And sometimes people really believe the injury wasn't serious enough to justify all of that. But that's why having a clear protocol is important. It removes that personal judgment from the decision.
And that mindset can actually create problems later because timing is really important in exposure evaluation. Documentation should happen promptly. Baseline labs are actually time sensitive, and early evaluation helps assess the risk. So, another thing that can affect reporting is the pace of the clinic environment. If the schedule is full and patients are waiting, people sometimes feel a crazy amount of pressure just to keep going.
Yes,
Have you
yes.
ever seen situations where workflow pressure influenced whether someone reported an exposure right away?
Yes, especially on days when the clinic schedule is very full or the team is short staffed. In those situations, people may feel pressure to keep things moving so patients don't fall behind. That pressure can make someone hesitate to report an exposure immediately, even if they don't know they probably should. That's why it's important for clinics to reinforce that employee safety is a priority, even when the workflow is busy.
Absolutely. And I feel like the theme of clinics or healthcare situations in general being short staffed is
Oh
probably
my.
around to stay for a little
For a
while,
long time, I
unfortunately.
feel
Yeah.
like.
So, I mean, that is just something that is going to be a pressure that we need to cope and we need to prepare for.
Yes.
So that's where workplace cultures become really important. If staff feel like reporting an injury is going to cause frustration or disrupt the schedule, they may hesitate to speak up. So, do you think healthcare workers sometimes feel embarrassed reporting injuries, especially if they've been doing the job for a long time?
Oh, I 100% agree.
Mhm.
Someone who has been doing procedures for years may feel like they should have been able to prevent the injury. That feeling can lead to embarrassment or self criticism, even though Sharp's injuries can happen to anyone. Sometimes people worry their coworkers or supervisors might judge them. But ideally, the culture should emphasize that reporting exposures is part of maintaining safety, not admitting failure.
Mm. Yeah, that's exactly why exposure reporting needs to be treated as a safety process rather than a personal mistake. Sharps injuries can happen even when someone follows every step correctly.
Mhm.
So, once the immediate first aid steps are completed, the next critical step is reporting the exposure to a supervisor or a designated safety officer. So, this allows for reporting to trigger an evaluation protocol, allows documentation to begin, and ensures employees receive appropriate care. So, do you think staff always know who they should report exposures to in their workplace?
Oh, that one can vary quite a bit depending on the organization. In smaller clinics, it might be very clear, like the clinic manager or the supervising provider. But in larger systems or hospitals, there can be multiple layers of supervision, and it might not always be obvious who the first point of contact should be. Shift changes and after hour situations can make that even more confusing if the normal leadership staff aren't present.
So, have you ever seen someone delay reporting until the end of their shift?
Yeah, I feel like I definitely have. It's actually more common than people think. A lot of times, it's not because someone is trying to hide it. It's usually, like we've talked about before, because they're busy, they're in the middle of patient care, or they think I'll deal with it later. But the problem is that with exposure incidents, especially things like sharps injuries, time really matters. The sooner it's reported, the sooner the exposure protocol can start, whether that's washing the area, notifying the right person, or starting post exposure evaluations. Waiting until the end of the shift can delay the process, and that's where risk increases.
Yeah, absolutely. So, do you think that new clinicians report exposures more quickly than experienced staff?
Honestly, I think sometimes they do. New clinicians are usually very fresh on the protocols because they just went through training, orientation, and competency checks. So when something happens, they're more likely to think, okay, step one is to report this right away.
Mm.
Experienced staff, on the other hand, sometimes feel like they've seen it all and they might minimize an exposure, especially if it seems minor. They might think, I've had a tiny stick before, it's probably nothing. But every exposure should be treated seriously, regardless of experience levels.
Yeah. Oh my gosh, I've had a stick before. It's probably nothing. That statement alone just freaks me out.
Literally gives me chills. I don't want to even think about
Oh,
that.
yeah. Oh my goodness. Okay, so what role do you think safety training plays in this?
Safety training is huge. It doesn't just teach people what to do, it reinforces why it matters. And that's the most important part. When training is done, clinicians understand that reporting isn't about blame, it's about protection. Good training also normalizes the reporting process.
Mhm.
If staff regularly hear, report it immediately. That's part of safe practice. It removes some of the hesitation. The more organizations emphasize safety culture and walk through the exposure response process, the more likely staff are to report it quickly and confidently.
Oh, yeah. So, all right, do you think some people worry that reporting an injury will make them look careless?
That's a hard one, but yes, I think so. But it's also kind of hard to like even think that in my mind at the same time because I'm the type of person that would be, let me report this right now.
Well, I can say that for me, at the time that I had my Sharps injury, I was a senior medical assistant. So I feel like there's always pressure. All of the younger medical assistants or less experienced medical assistants are looking at me. So, how does that make me look that I had that
For sure.
experience occur? So, I don't know if I felt like at that time it made me look careless, but it definitely ran across my mind
Like
that
who's watching you?
who's
Like,
watching me? I'm
hmm,
supposed to be a leader.
yeah,
And look at me. I made this mistake. This thing happened to me. For whatever reason, the protocol wasn't the first thing in my mind.
yeah. No, I get that. I feel like we think of like, oh my goodness, people are watching me. I'm embarrassed about it. It's not that we're careless. It's more of like I'm supposed to set an example for everybody else, or
Yeah.
like,
And like, look at this mistake that I
yeah,
made.
look what you
Yeah.
did. Like, yeah,
Yeah. So the immediate response after an exposure really involves two priorities: taking care of the wound itself and activating the reporting system so the evaluation process can begin. And once that report is made, the next step involves the supervisor's response, which can play a huge role in how the rest of this situation will unfold. So, once an exposure has been reported, the next step involves the supervisor response. And honestly, this is where exposure management often succeeds or fails. Because the tone set by leadership in those first few minutes can influence everything that follows. In a well functioning system, the supervisor's role should be calm, procedural, and supportive. Something to the extent of, thank you for reporting this. Let's get this evaluated. I'll handle coverage from here.
hmm,
Wouldn't that be remarkable?
yes,
In these heightened stress moments, having a leader actually lead and not put more on you does so much. It reassures the employee, it keeps workflow moving, and most importantly, it avoids blame and that negative, toxic shame culture that can come around with this, especially for people that are high performing, high expectations, strong work ethic,
yes,
right?
yes. People
So,
that really uphold their like value in the clinic, like
right, absolutely. So, Kirsten, when you think about real healthcare environments, What kind of reactions have you seen from supervisors when someone reports a sharps injury?
Hmm. I've seen a couple different reactions. In some clinics, like my first clinic, supervisors respond exactly how they would hope: calm, supportive, and focused on getting the employee evaluated quickly. But in other situations, the first reaction might be surprise or frustration, especially if the clinic is already running behind.
Sure. They're stressed out themselves, and you
Yeah.
just gave them a new stressful
Yep,
thing to
they just
think
got
about.
something added right on top.
Okay.
Sometimes the supervisor immediately starts asking detailed questions about how the injury happened. Those questions may be important later, but in the moment, the employee mainly needs reassurance and guidance about what to do next.
Absolutely. And sometimes those reactions happen without the supervisor even realizing how they
Oh, for
sound,
sure.
right? A supervisor needs to manage several moving pieces at once: stress of the busy clinic, pressure to keep the schedule moving, and their concern about staffing. Those are the supervisor's job. That's what they're there for, to manage these situations well. Do you think supervisors sometimes unintentionally make staff feel like they've done something wrong just by the way they respond?
Yes, and I think it's done most of the time without realizing it.
Hmm.
Even something as simple as immediately asking, "How did that happen?" can make the employee feel like they're being blamed.
Yeah.
The supervisor may just be trying to understand the situation, but the tone and timing of those questions can really influence how the employee interprets the response.
Oh, totally.
If the first focus is on the investigation rather than the support, it can make people more hesitant to report future incidents, I feel like.
Yeah, that's where safety culture becomes really important. If staff believe reporting an exposure is going to lead to criticism or frustration, they may hesitate to report future injuries. So, what do you think good leadership looks like in the moment when someone reports an exposure?
I think good leadership in the moment is calm, clear, and focused on the process. The supervisor should acknowledge the report, thank the employee for speaking up, and immediately guide them through the next steps. It also helps when the supervisor reassures the employee that the clinic will manage the workflow while they get evaluated. That kind of response shows that the organization values both employee safety and transparency.
Yeah, definitely. So, one thing I think about a lot is that supervisors often have two responsibilities at that moment. First, to support the exposed employee, and second, to maintain patient care workflow.
For sure.
So, both of those are ideally should be able to happen simultaneously. But,
Yes.
Kirsten, how do you think supervisors can balance those two responsibilities, supporting the employee while also making sure patient care continues?
I think that balance comes down to teamwork and planning. The supervisor can quickly redistribute patients, ask another staff member to step in, or temporarily pause a procedure if needed. Most clinics already adapt to unexpected situations like emergencies or staff illnesses, so responding to an exposure can be managed in a similar way.
True.
The key is making sure the employee doesn't feel like they have to choose between reporting an injury and keeping the clinic running.
Yeah, absolutely. So, another factor is that not every supervisor has been formally trained in exposure response procedures, and this could be due to promotions based on a clinical skill, or leadership training might have been delayed. Do you think that supervisor training sometimes focuses more on scheduling and workflow than on safety leadership?
I think that in many organizations, supervisors are promoted because they're strong clinicians or reliable team members. But leadership roles often come with responsibilities that go beyond clinical work, including safety management.
Hmm.
Sometimes that training happens informally rather than through structured programs. So supervisors may learn how to handle exposure situations only after one has actually happened.
Okay, on the job training for that.
Yeah.
So that's why exposure response protocols should be clearly defined and practiced. If the supervisor knows exactly what the next step is, they don't have to improvise. Could you imagine only knowing what to do when a fire happens, when it occurs, versus having fire drills? It's kind of similar. There
Yeah.
should be some established workflow in place to allow for faster evaluation, less stress for the employee and for the supervisor, and an overall smoother workflow.
Oh, for sure.
Yeah.
Yes.
Do you think that clinics sometimes assume everyone already knows what to do in these situations?
Yes, that assumption happens a lot because exposure protocols are written into policies. Organizations sometimes assume that staff remember all these steps, but without regular refreshers or practice scenarios, it's easy for people to forget details. That's why safety protocols work best when they're reinforced periodically rather than only mentioned during orientation, like staff trainings.
Yeah.
Staff meetings, we can go over, oh, let's go through the safety protocols. What do
Yeah.
you know what to do?
Yeah, absolutely. And, like, I don't want to, be devil's advocate here, but then I can see for really short staffed or busy clinics being like, when am I going to have time to do all of these trainings to
hmm
be on top of it? But honestly, like, you have to prioritize safety.
Yeah, for sure.
You have
It's,
to. Like, you can't just be like, well, we're really busy, so let's just run our ship into the ground until we can't keep going because everybody drowned in the ocean.
yeah,
Like it's ridiculous.
yeah,
You have to invest in these kind of trainings in order
for sure.
to keep things functioning in a healthy way rather than just barely
And we
surviving.
can also look at it as a bonding situation.
Yeah.
Like, hey, let's learn all together.
Let's learn all together and then go do paintball afterwards.
Yeah, let's do it.
Oh, okay. All right. So back on track. Have you ever seen a really good supervisor response to an exposure?
Oh, definitely. I remember one time a coworker had a needle stick, and the supervisor didn't just hand her the forms. They stayed calm, walked her through each step, made sure she would wash the area, contacted occupational health, and even checked in later that day. It wasn't about scolding, it was about support and clear guidance. That kind of response makes a huge difference in how staff perceived reporting.
What made that response most effective, do you think?
I think a few things. One, clarity. Everyone knew exactly what to do. Two, empathy. Empathy super important. The
Mhm.
staff member felt supported and not judged. Not judged, remember that. That's very, very important. And three, speed. The supervisor acted immediately to make sure the exposure protocol started without delay. It gave the message that safety is a priority and reporting is expected, normalized, and supported.
Yeah. So, what role does trust in leadership play in reporting?
Trust is huge. If staff feel that leadership will respond fairly without judgment, they're far more likely to report quickly. But on the flip side, if someone worries that reporting will create blame or unnecessary hassle, they might delay or avoid it. Building that trust through consistent support, clear policies, and follow up makes reporting feel safe and routine instead of risky.
Absolutely. Exposure response should feel procedural, not like they're improving. The moment someone reports an injury should activate a process, not a debate about what to do next. Once the supervisor activates that process, the next step is medical evaluation, and that's where regulatory guidelines become especially important. So, once the supervisor has been notified and the reporting process begins, the next step is medical evaluation. This is the part of the process where clinical guidelines and regulatory standards really come into play. Post exposure evaluation is designed to assess the risk of infection and determine what follow up care may be needed. Per OSHA, workplace safety regulations require that healthcare workers who experience an occupational exposure have access to a prompt medical evaluation. And these evaluations typically include documentation of the exposure, baseline laboratory testing, risk assessment based on the type of exposure, and follow up testing as indicated. So, Kirsten, when you talk to clinicians about exposures, what do you think people are most uncertain about when it comes to the evaluation process?
Hmm. When I talk to staff about exposures, one of the biggest things I notice is uncertainty about what's actually going to happen during the medical evaluation. People often wonder which labs will be drawn and how long is follow up testing going to take. They might also ask about exactly which infections are being screened for, like hepatitis B, C, or HIV. Some clinicians assume that if they feel fine, there's nothing to worry about, but many infections are asymptomatic at first. There's also anxiety around risk. Even if the likelihood of transmission is low, people want to know, am I safe? Do I need medication? Explaining the process and the timeline really helps people feel more in control and less stressed when waiting for a response.
That's a really common question. Most exposure evaluations include baseline testing for bloodborne pathogens such as Hep B, Hep C, and HIV. Baseline labs help establish the employee's status at the time of the exposure. So, if they have any positives during the baseline, that would indicate that they were positive prior to the exposure. And then follow up testing monitors for potential seroconversion. So, do you think that clinicians sometimes assume that if they feel fine after an exposure, there's really nothing to worry about?
Yes, I feel like that's a pretty common misconception. People sometimes think any sharps injury is equally risky, but risk actually depends on multiple factors. Whether it was superficial scratches or a deep puncture, whether the sharp was a hollow bore, and whether it was visibly contaminated. Also, the medical history of the source patient, if known, changes the risk assessment. It's really important for staff to understand that not all exposures are created equal and that the evaluation process is designed to figure out the actual level of risk.
Yeah. And another important part of the evaluation is assessing the type of exposure. So, risk depends on factors such as the depth of the injury, the type of sharp involved, whether the sharp was visibly contaminated with blood, and the medical history of the source patient if that's known. So, do you think that people sometimes assume that all sharp exposures carry the same level of risk?
Yeah, that's something I see a lot. People assuming all sharps exposures are basically the same. But there's actually a big difference between, say, a superficial scratch and a deep puncture. The type of device matters too. A hollow bore needle carries a higher risk than a solid lancet or scalpel. So even if it looks small, the exposure could be more serious depending on the device and the depth. That's why every exposure needs to be treated seriously and reported right away.
Very true. So, another aspect of evaluation that people sometimes wonder about is the post exposure prophylaxis. HIV exposures may require prophylaxis medications. Hepatitis B protection may depend on vaccination status, and hepatitis C typically involves monitoring rather than prophylaxis. So, do you think clinicians sometimes expect immediate answers after testing, when in reality, some follow up testing happens weeks or months later?
I think we would see this a lot. Clinicians expect immediate answers or medications for every exposure. In reality, prophylaxis depends on the type of exposure and the patient's vaccination status. For example, HIV may require prophylaxis, hepatitis B might not if the employee is already immune, and hepatitis C usually involves monitoring rather than preventative medication. Waiting for follow up labs can also create anxiety, especially if staff expect immediate clarity. So, part of education is helping people understand the steps of the process and why some testing happens over weeks or months.
Absolutely. Follow up testing may occur at intervals, such as several weeks out from the exposure incident to several months after. So these timelines are designed to detect infection if it develops. What do you think clinics can do to help staff feel supported during that waiting period?
Clear communication is huge. Staff need to know what labs were drawn, when follow up tests are scheduled, and who they can contact if questions come up. Reassurance is another key piece, reminding them that most exposures don't result in infection and that the process is designed to monitor safety. Even small check ins from employee health or supervisors can reduce anxiety and make staff feel supported while waiting for results.
Yeah, education, it plays a huge role here. When clinicians understand what the evaluation process involves and why follow up testing is needed, the situation can feel much less overwhelming. Another important part of exposure management is identifying and testing the source patient when possible. So let's talk about how that part of the process works.
Let's do it.
Okay. So once the exposed employee has been evaluated and baseline testing has been completed, another important part of exposure management involves the source patient when one can be identified. Source patient testing can help determine whether the exposure carries meaningful infection risk of HIV, hepatitis B, and hepatitis C. Kirsten, when people talk about exposures in clinical settings, I think the part that causes the most anxiety is the source patient's piece. Why do you think that is?
I think it's the uncertainty. Staff often worry about whether the patient will consent or they fear a positive result and how that will affect them. Many clinicians don't fully understand how source testing works, including the consent process. Some assume it's mandatory, but in reality, patient autonomy and privacy rights must be respected. That can feel stressful when you're trying to assess your own risk.
Absolutely. And unfortunately, HIPAA also plays a huge role here because as providers of care, we have access to their medical records.
Mhm.
That does not mean that we can just dive into their chart
Mhm.
and go and look at when they were last tested for HIV to see if we're good.
Yep.
That absolutely is over the line and violating a patient's privacy because that's not relating to their care, it's relating to
Yep. That's
ours.
ours.
Yeah. So, and another factor is that clinicians don't always know what happens if the patient declines testing. So, source testing requires consent in many situations. Refusal must be documented, and the exposed employee still receives the follow up care. So, do you think clinicians sometimes assume that source patient testing is mandatory?
Clinicians sometimes panic thinking the process is stalled. But even if the source patient refuses testing, the exposed employee still gets a full follow up care. The documentation needs to reflect that consent wasn't given, but from a safety standpoint, the evaluation and monitoring process continues. Staff just need to understand that their care doesn't depend entirely on the source patient.
Yeah, that's a really good point. Um, even if Even in exposure situations, patient consent and privacy rights still apply, like we just mentioned. So, healthcare workers must respect patient autonomy,
Yes.
and exposure protocol accounts for situations where testing is not possible. So, you weren't with me during the last episode where I reviewed my own Sharps injury experience, where the source patient initially consented to testing but never ended up doing the testing.
Mhm.
So, have you ever seen situations like this where the source patient initially agreed to testing but didn't follow through?
Yes, I've seen that happen, but I feel like that's not always the case. I think most of the time people are like, oh, yeah, let me do it. But sometimes the patient leaves before labs are drawn, or there's difficulty contacting them later. That can create extra uncertainty for the exposed employee.
Oh, yes.
In those cases, risk assessment relies more heavily on details of the exposure itself rather than the patient's lab results. Education and reassurance about what steps will be taken can really help reduce the stress.
Yeah, and when that happens, it can create additional uncertainty for the exposed employee. So, follow up testing becomes even more important.
Mhm.
And risk assessment relies more heavily on the exposure details, like we were talking about earlier, like depth of the puncture, what
Mhm.
was the instrument involved in the exposure in the first place, what is the
Yes.
level of risk we're evaluating there. So, what do you think healthcare workers worry about the most while waiting for information about the source patient?
It's definitely the what if scenarios. What if the patient is positive? Or what's my actual risk?
Hmm.
Those waiting periods can feel long, especially if staff aren't familiar with the timeline or follow up testing. Education about risk levels, expected timelines, and communication channels can help reduce anxiety during that period.
That waiting period can be so stressful, especially when clinicians are unfamiliar with how risk assessment works. Like in my own experience, I know that I was logged into my chart, refreshing those lab results
Sure.
like multiple times a day. I needed to know. I was so stressed out about it. And many exposures, luckily, carry a very low risk. And the structured follow up helps monitor safety. So, all of these steps are designed to help make that process a little bit better, but the information isn't always there with the employee. So, do you think education about exposure risk and follow up testing would help reduce some of that anxiety?
Absolutely. Education can make a huge difference in reducing anxiety after an exposure. When staff understand the actual risk and what follow up testing involves, it takes away a lot of the unknown. I feel like training programs that go beyond just here's what to do and explain why each step matters really help. and clear, consistent communication during evaluations. Letting people know what's happening when results come and what the next steps are can calm their fears and make the whole process feel more manageable.
Yeah, understanding how source patient testing works and what happens if it doesn't happen is an important part of helping clinicians feel more prepared for these situations. So far, we've talked about the immediate response, supervisor involvement, medical evaluation, and source patient testing. Another critical component of exposure management is documentation.
Mhm.
Documentation might not be the most exciting part of the process, but it's incredibly important for both employee safety and regulatory compliance. Reports like an incident report, exposure reports, employee health documentation, and the SHARPS injury log entries. Some of these forms, if not all of them, are involved in the Needle Stick Safety and Prevention Act. And this law requires healthcare employers to maintain these SHARPS injury logs to track occupational injuries involving contaminated sharps. Kirsten, when you think about incident reporting in healthcare, why do you think documentation sometimes gets delayed or avoided?
Honestly, the biggest reason I feel like is usually time and stress. Like we've talked about before, clinic environments are busy, and at the end of a shift, staff are fatigued. Filling out incident reports isn't usually anyone's favorite task.
No,
It's not mine for
definitely
sure.
not. Yeah.
Sometimes staff also feel pressure from the workload or worry that reporting will make them look bad. But skipping documentation can actually slow down follow up care and make the risk assessment harder and reduce the opportunity to prevent future incidents.
That's something we see across many healthcare environments. After a stressful event, the last thing someone wants to do is fill out paperwork.
Mm-mm.
Documentation triggers follow up care, helps identify patterns of injury, and supports regulatory compliance. These are all super valuable components of an injury report. So, do you think some clinicians view incident reports as punishment instead of prevention strategies?
Yeah, that perception is probably really common. Even if the organization has a non punitive policy, staff may fear that submitting a report will trigger disciplinary action or judgment from supervisors. It's really important for leadership to frame documentation as a safety tool, a way to prevent future injuries and improve systems, not as a report card on a performance.
Absolutely. Ideally, documentation should be viewed as a safety tool rather than a disciplinary process. This data helps improve safety systems and it helps organizations identify equipment or workflow problems. So, have you ever seen a situation where incident reporting actually led to a safety improvement?
Actually, I have. I've seen cases where reporting a Sharps injury led to real changes, installing safer Sharps containers, updating procedures, and even conducting mini training refreshers for staff. When done correctly, documentation can help organizations identify patterns of injury and create safer working conditions. That's why making the process clear and non punitive is so important.
So, when incident reports are used correctly, they can help organizations prevent future injuries. But documentation alone is not enough. Another important part of exposure management is how organizations communicate with employees during follow up. So, once documentation is completed and the evaluation process has begun, the next part of exposure management involves something that often gets overlooked: communication and follow up.
Dun dun dun.
Dun dun dun. Even after the initial evaluation is finished, the exposed clinician may still have weeks or months of follow up testing ahead. And that waiting period can be one of the most stressful parts of the entire experience. Kirsten, when clinicians go through exposure evaluations, what do you think they worry about the most during the waiting period?
100%, like I said before, the uncertainty. People worry about whether they might have been infected, whether they'll get their lab results on time, or what the follow up schedule actually looks like. Even if the risk is low, the lack of clear communication can make the waiting period feel super overwhelming.
Oh, yeah, that uncertainty can really weigh on people. Even when the risk of infection is so low, the lack of clear information can make that situation feel overwhelming. Follow up testing schedules exist for safety, And most exposures do not result in infection. Those are the key points to remember.
Mhm.
Do you think clinicians always leave their initial evaluation with a clear understanding of what happens next?
Not always. Instructions can be rushed, and stress during the exposure event can make it hard to absorb all the details. I know I forget things when I'm super stressed out.
Fair, yeah.
People sometimes forget what labs were drawn, when repeat testing will happen, or who to contact if they have questions. Providing written instructions, contact information, and follow up check ins really helps staff feel supported.
Ideally, exposed employees should leave their evaluation with a very clear understanding of those next steps. They should know what labs were drawn, when repeat labs will occur, and who to contact with additional questions. So, what do you think clinics can do to improve communication with staff during that follow up period?
I think simple things make a big difference. Written instructions, a clear schedule for follow up labs, and a point of contact for questions all help. Leadership should also check in periodically. Just asking how the employee is doing and making sure appointments are scheduled shows that the organization cares about safety and well being.
Yeah, and something else that can make a big difference is simply checking in with the employee after the incident. Supervisors acknowledging their experience, asking how they're doing, and making sure follow up appointments are scheduled. Do you think leadership sometimes assumes that once the initial evaluation is complete, the situation's basically over?
I don't think that they mean to, but I feel like with the busy clinical environment, it does get happen a lot. Once the initial evaluation is done, leadership's attention often shifts right back to their daily workflow, and it's easy for ongoing employee concerns to go unnoticed. But for the staff member, the exposure isn't necessarily over. There's still anxiety, follow up testing, and questions about that risk. That's why continuous support and check ins are so important, not just the first response.
The situation may still feel very active, especially if they're waiting for follow up testing. So, good communication. It helps reduce anxiety. It reinforces trust in the organization and it encourages future reporting. What role do you think workplace culture plays in whether staff feel supported after an exposure?
Culture is huge. In supportive environments, staff feel comfortable reporting exposures and asking questions. In environments where concerns are dismissed, staff may hesitate to report anything, which in the end increases that risk. Peer support and leadership empathy make a real difference in how staff experience exposure events.
That actually leads into something we're going to talk about more in our next episode, the psychological side of exposure events and how workplace culture influences reporting. Before we wrap up today's discussion, I think it's helpful to talk about some of the most common system failures that can occur during exposure management.
Yes.
Throughout this episode, we've talked about what an ideal exposure response system should look like. But in real healthcare environments, things don't always go perfectly. So I thought it would be helpful to talk about some of the most common system failures that can occur during exposure management. Kirsten, when you think about exposure response in real clinical settings, what do you think is the one most common breakdown that can occur?
Oh man. Some of the most frequent issues I see are confusion about next steps, delayed reporting, and inconsistent supervisor instructions. Training gaps are another major problem. If staff haven't practiced or revisited the protocol, they might not know exactly what to do when an exposure
Oh,
happens.
yeah. And one issue that comes up a lot is uncertainty about after hours procedures. Employee health may not be available, staff may not know whether to go to the emergency department, and instructions may not be clearly communicated. Do you think clinics always make their after hours exposure protocols clear to staff?
I don't think so at all. Not always for sure. Employee health offices may not be available, and staff may not know whether they should go to the emergency department or follow another procedure. Sometimes after hour steps are mentioned once during orientation, then forgotten until an incident occurs.
And another common issue is supervisor training. Supervisors may be excellent clinicians, but may not have received formal safety leadership training. So, do you think leadership training in healthcare sometimes focuses more on operations than on safety culture?
Oh, for sure. Training often focuses on operations way more like scheduling, staffing, and workflow. Safety leadership may only be addressed after a real incident occurs, which means supervisors are improvising in the moment instead of following a practice plan.
Mm. Okay, so another factor we talked about earlier is workplace culture. So, supportive environments, encouraging reporting, and blame focused environments, discouraging reporting. If a clinic wanted to improve its exposure response system tomorrow, what do you think would be the single most important step that they could take?
I'd say the biggest step is creating clear, simple, and practice protocols that everyone knows. That includes immediate response, reporting chain, documentation, and follow up steps. When staff know exactly what to do and leadership supports that process, it makes everything faster, safer, and less stressful for everyone involved.
That is a great point. Exposure response systems don't have to be complicated, but they do have to be clear, consistent, and practiced. So, with that in mind, let's wrap up today's discussion with a few key takeaways. Today, we talked about what a gold standard exposure response system should look like, from the immediate response after an injury to documentation, communication, and follow up. Exposure response should be procedural. Leadership tone affects reporting culture. Clear communication reduces anxiety. Documentation supports safety improvement. Thank you for listening to Vitals and Veins, where we talk about the real world practice of healthcare, from specimen collection to clinical safety. Until next time, take care of your patients, take care of your team, and never underestimate the importance of good clinical practice.